Hi, everyone. My name is Roach, and I'm the Executive Director of the Minnesota Nurses Association. I also represent M&A on the board of the Healthcare for All Minnesota Board of Directors, and I'm also a member of the steering committee of the Labor Campaign for Single Payer. Greetings of health and solidarity from your nurses. For half a century, the United States has been steeped in incremental, market-driven reforms of our healthcare system that simply don't work. And why don't they work? Because we insist on treating healthcare like a commodity using a business model format. These failed solutions continue to permeate the healthcare reform debate to this day. The false claims of efficiency and effectiveness in these market-based solutions needs to be exposed. That's why I've titled my presentation, HMOs, PPOs, ACOs, and EIEIOs, How Managed Care Hog the Spotlight of Healthcare Reform. Understanding how we got where we are is critically important in our fight to win single payer. I also want to note that some of this information is historical. It's needed so we can clearly see why we are where we are and hopefully stop us from continuing to try the same failed strategies over and over again, expecting different outcomes. A presentation disclaimer for you. You're going to see a lot of words because this is a presentation of substance. But it's not just me or the nurses or the doctors or single payer advocates who say that the managed care diagnosis and solution to our healthcare crisis is a failed strategy. It is, in fact. I want to start by providing an overview of what I will be talking about. Managed care ideologies have a diagnosis that says it's all about the high cost of healthcare and its actual impact on cost containment. Has that actually panned out? What is their diagnosis? And has it been working? What's the real explanation for the high cost of healthcare in the United States, including some Minnesota-specific examples? That's where I'm from, so I've got some good ones for you. Accountable care organizations, ACOs, and value-based payments, nothing more than managed care 2.0. So let's start out with a few definitions. Love to have lots of different acronyms, in the healthcare universe. So when I talk about privatization, I'm talking about the shifting of the provision of a service from government to private sector entrepreneurs. Capitation is paying doctors, chains, or insurance companies a set or uniform fee per year per enrollee, meaning per patient. FFS, fee for service, paying doctors a fee after they render a service as opposed to paying them via salary or capitation. HMO, health maintenance organization. ACO, accountable care organization. IHP and IDS, integrated health partnerships, integrated delivery system. And CMS, that one probably you're most familiar with, Centers for Medicare and Medicaid Services, which is, of course, the agency that runs our Medicare and Medicaid programs. So, managed care's ideology, their diagnosis of the high cost of healthcare and its impact on cost containment. So, since the 1970s, managed care ideologues have been trying to diagnose our high cost of healthcare system. But is it an accurate diagnosis, and has the prescribed treatment worked? Well, not so much. So I'm going to say thanks to Dr. Anna Manilow of PNHP for this slide. Many of the health economists hold on to this idea that excessive healthcare costs in the United States are due to two things. One is physician greed, and the other one is patients are getting too much care. And in other words, where they're coming from is that the fee-for-service model, it pays for volume. So their solution is to squeeze physicians and to squeeze patients. So the way that they squeeze physicians is through these different types of capitated payments for certain populations of patients. And they do that by creating HMOs and ACOs and PCPs and MCOs and many, many other types of things, including the newest reiteration, which is DCEs, direct contracting entities. Then you squeeze the patients, and you do that by making them stop getting so much healthcare, because that's what we want from a healthcare system. You increase deductibles, copays, and coinsurance. You underinsure them. You make them choose between a whole pill or a half, 3 meals a day or 2, And this basically is how the US uses market forces to quote unquote control prices. Here in Minnesota, I want to give you a couple of examples here specific to Minnesota. The notion that doctors cave in to the fee-for-service incentive, which has absolutely become some kind of groupthink. In reality, there is no evidence to support this claim, which I'm going to talk more about in a bit. In Minnesota, insurance companies were very quick to jump on that overuse and fee-for-service as the problem bandwagon, and they certainly made our elected legislators know that they wanted in on this. Minnesota happens to be a high-cost state, and the reason we are is because we're a high-price state. We spend more per capita than the national average, ranking 36th in a 2009 CMS study that was done. Yet we have a low rate of emergency room visits and hospital admissions, while length of stay and readmissions are close to the national average. Proven again, it isn't really about the overuse of healthcare. And in 2016, we're deemed to be among the nation's highest in healthcare prices. So how do we keep pretending that price doesn't matter? Rising administrative costs plus consolidation absolutely has driven up costs. Administrative costs are, of course, a component of price. Just look at the explosion of administrative costs between 1980 and 1991, a time when managed care was actually all the rage. Not only do we see a significant increase in healthcare costs themselves, but there was a 502% increase in administrative costs. And we can't ignore the impact that this ideology has had on bringing about massive mergers and consolidations within our system. Again, in my home state, consolidation has played a major role in our average healthcare costs, moving us from the category of average costs to becoming a high-cost state. Consolidation and merger frenzy has been a direct result of managed care, and it is not bringing healthcare costs down, but it is causing significant stress to our direct care providers. You hear about nurses and doctors burning out. First of all, nurses and doctors reject that characterization. Being burnt out puts the burden on the doctor or nurse and implies a lack of character. No, what our care providers are experiencing is moral injury. Moral injury occurs when clinicians are repeatedly expected in the course of providing care to make choices that transgress their long-standing, deeply held commitment to healing. Moral injury is caused by something beyond the control of the doctor or nurse, not a personal failing that they can fix with self-care. Consolidation within the health insurance sector, the giants, have made it almost impossible to enter the healthcare marketplace. You can see by these quotes that consolidations and mergers within our system make it clear that the fallacy of this common claim by those that are opposed to single payer particularly, that we will be robbed of choice if we move to Medicare for all. But this isn't only about health insurance companies. Hospitals are also engaged in consolidation merger mania, which again results in higher prices. We're down to basically 8 major hospital corporations here in Minnesota, as noted on this slide, from the far north to the far south and everywhere in between. The privatization scheme only adds to the workloads of both our government agencies who are overseeing these programs, and as I noted earlier, to the direct care providers themselves. All of this adds, does not subtract from the cost of healthcare. Turns out the prescribed treatment for the inaccurate diagnosis that we overuse healthcare because we pay for it based on fee-for-service ended up doing nothing to contain costs and actually did the opposite, driving prices up through added administrative costs and these market consolidations. You can see that here in the quote that says, we find that higher levels of local managed care penetration are associated with substantial increases in consolidation in hospital and physician markets. Again, price drives cost, cost gets driven by this kind of nonsense. And the truly saddest impact has been the fact that HMOs are harming the sickest patients. We only have to look at what's happening within Medicare to see how the industry, as we say, cherry picks the healthiest and lemon drops the sickest. For elderly patients treated under Medicare, declines in physical health were more common in HMOs than in fee-for-service plans, 54% versus 28%. And the other quote that I think is relevant from the New England Journal of Medicine, the Medicare HMO revolving door, the healthy go in and the sick go out. In the early 90s, a study was done here in Minnesota that demonstrated how the HMOs and managed care were not working. It wasn't necessarily mentioned to arrive at that conclusion, but it did when it comes to decreasing health disparities. But the study, interestingly, was never published. This quote from the Minneapolis Star-Tribune article about the study being shelved because the HMOs complained about it demonstrates the inequity that exists in our healthcare system that was not and is not being addressed by managed care. In reality, it's exacerbating disparities, particularly racial health disparities. We cannot effectively address health disparities and inequity until we change the financing of our system. And also, as it turns out, the math doesn't really compute. This quote from a 2006 article in the Wall Street Journal makes that very point. States that run their Medicaid programs themselves without the private sector involved shows an average administrative cost of 4 to 6%, meaning 94 to 98% goes to paying for medical care. Insert the private sector, also known as an HMO, and now only 80 to 85% of those precious healthcare taxpayer dollars are going to direct medical care for patients. Not a very cost-effective or efficient way to run a healthcare system. And here's the thing. In the 90s, it became clear after almost 2 decades of playing around with this managed care idea that it doesn't work. We get into the early 2000s, and guess what? Still no conclusive evidence to support this notion. And that's what it was and still is, a notion that managed care somehow saves money. 95, there is little evidence, however, to suggest that managed care either increases or decreases the number of physician visits or the use of preventive health services or the use of inpatient hospital care. And then in 2006, you can see still no evidence for managed care 1.0 that it worked. We still do not know conclusively to what extent traditional managed care actually saves money. And in 2013, a Commonwealth Fund summary of a systematic review notes that the researchers found no consistent evidence indicating that any particular system of care or insurance, whether fee-for-service or managed care, has been more effective than another in minimizing overuse. Managed care doesn't control costs, it doesn't improve quality, and it's no better than fee-for-service at reducing the enigma of its own diagnosis on what's driving costs that they claim is overuse. In 2001, the former editor of the Journal of the American Medical Association proclaimed, managed care is basically over, people hate it, and it's no longer controlling costs. Further asking a really pertinent question, if it's not saving money, then why should we have it? He astutely notes, however, that dismantling it will be messy. He's so right, as we see managed care 2.0 rear its ugly head not long after this article was published. So let's just take a few minutes to talk a little bit about what the real explanation is for the high costs of healthcare in the United States and here in Minnesota as well. Because when we dig a little bit deeper in the real healthcare cost drivers, and we can see whether or not the managed care diagnosis of overuse and fee-for-service is really a correct diagnosis. To quote both Princeton economics professor Uwe Reinhardt, it's the price is stupid, and Gerald F. Anderson article in Health Affairs in 2003, He said it a little less bluntly, but he said it nonetheless in saying that the United States spends more on healthcare than any of the other OECD countries spend without providing more services than the other countries do. This suggests that the difference in spending is mostly attributable to higher prices of goods and services. This same story is told by other researchers. From the Lancet in 2014, prices rather than volume of health services contribute the most to explaining the higher U.S. spending. I want to provide a couple of examples of high prices, starting with hospital charges. An OECD study done in 2010 found U.S. price levels of hospital services to be 60% higher than the average of 12 other OECD countries in 2007. Unfortunately, as you all know, healthcare data is always 2 to 3 years behind before the new stuff becomes available. But in 2015, the International Federation of Health Plans published a comparative price report which demonstrates in hard numbers what that pricing looked like, as you can see by the screen here on the right-hand side. Spain at $424, the US at $5,220 as average price. Getting even more specific, when we look at a couple of common procedures, knee replacement and angioplasty, we see the same trend as overall hospital charges. This plays out, as we all know too well, in the price of pharmaceutical drugs as well. Just look at that drastic cost difference between some of the other industrialized nations of the world who provide healthcare for their citizens and the United States. And where is the difference? It's in the price. We can't forget this culprit, the enormous waste within our system due to the fragmentation and the complexity of the system itself, which creates excessive and unnecessary administrative costs at every level of engagement with the system. Just look at the difference in administrative costs when comparing our Medicare system and Canada's Medicare system that covers all Canadians, not just those 65 and older, against a private insurance company administrative cost. And that 34% doesn't include the cost a patient and employer pay in terms of their time and resources when having to deal with this convoluted system. The managed care theory that healthcare costs in the United States are high due to overuse in a fee-for-service payment model was actually studied by Deborah Kornstein et al. In a study entitled Overuse of Healthcare Services in the United States, an Unstudied Problem. It was published in the Archives of Internal Medicine in 2012. Interestingly, the editor of that same publication, Michael H. Katz, wrote a follow-up to the publication of the study entitled Overuse of Healthcare. Where is the data? He was so struck by how little evidence Kornstein et al. Found that he felt compelled to comment on it. He said what is most striking about this report is how hard the authors searched for data on overuse of healthcare and how little they found. They viewed 21 years of the medical literature and evaluated 114,831 publications, yet found only 172 articles that addressed overuse. The question Katz asked, where's the data, is a good one. After a half a century of screwing around with HMOs, PPOs, and ACOs, all of which were promoted in the name of reducing overuse caused by fee-for-service, you'd think we'd have some solid evidence by now of an epidemic of overuse. We still don't. And for the small pockets of overuse that do exist, we have no evidence that they are caused by fee-for-service. So the bottom line is on the managed care diagnosis of overuse due to the payment system based on fee-for-service is it doesn't hold up. As published in a Health Affairs article in 2001, quoting, in fact, a direct association between fee-for-service payment and overuse has never been established. Fee-for-service isn't perfect, but it's not the core culprit of high costs. We're paying the wrong fees for the wrong services. For example, we pay more for a knee replacement surgery, which, by the way, is very lucrative for hospitals, than we do for mental health services. In that way, we do need to reevaluate fee-for-service, but not because it's the sole reason for the high costs overall. It isn't, but because we need to bring parity to our care delivery system. But how do we do that when we have no consistent payment system to begin with? And it's important to note that underuse in our system is far more prevalent and costly to our system than is overuse by a factor of 4 to 1. People choose not to access the system, and that's due to the number one barrier, which we all know is cost. Yet with all that, what do? Well, as George Carlin used to say, I don't believe there's any problem in this country, no matter how tough it is, that Americans, when they roll up their sleeves, can't completely ignore. Well, what we appear to be ignoring is not so much the problem, but the obvious and proven solution. ACOs, they're based on the same flawed theory as HMOs. It's an assumption of the problem being overuse, no evidence to support that assumption. It's based on an aspiration for achieving lower costs and then improving quality, but it results again in even more mergers and consolidations, and it has failed in its aspirations to date to cut costs and improve quality. Insurance companies saw a real opportunity with ACOs, quickly setting up their own. Here's that aspiration getting tossed on its head as the healthcare market sharks smell blood, pun intended. Humana Medical Director Dr. Tom James said the insurers want to show that health plans have a role with ACOs, adding that it's important that ACOs be seen as more than cost cutters. If not done right, it could give the whole movement a bad name, he said. We learned that with HMOs in the 1990s. And consolidation becomes centered in the rush to establish ACOs. When Congress passed the healthcare law, the Affordable Care Act, it envisioned doctors and hospitals joining forces, coordinating care, and holding down costs. Now, 8 months into the new law, there is a growing frenzy of mergers involving hospitals, clinics, and doctors' costs, not the intent that they were spelled out for. Interestingly, not even a CMS contractor could explain how an ACO was supposed to reduce overuse, stating it's a financial arrangement wherein provider organizations attempt to reduce expenditures below a set target while maintaining high quality metrics. That's a presentation unto itself, in exchange for bearing some of the risk for reducing expenditures. Here's the thing. Again, none of the CMS ACO programs have actually saved money. The MSSP stands for the Medicare Shared Savings Program, which is the largest of the 4 ACO programs that CMS has conducted. The MSSP is a permanent program. It was created by the Affordable Care Act. And all the other ACO programs that have been implemented after 2010 were brainstorms of the Center for Medicare and Medicaid Innovation Center, also created by the Affordable Care Act. The MSSP is by far the largest of the ACO programs, making a quote about its trivial effects on quality particularly worth noting. Also, it's important to note that CMS does not take into account the costs involved in setting up an ACO on the front end. When you do, any tiny savings that is reflected here, 0.3%, quickly evaporates. So there is that question about the improvement of quality, because we certainly want to improve quality. Do they? Do ACOs improve quality? Again, not so much. Small improvement on a few quality measures, no impact or slight worsening on some of them, as demonstrated here by a report to Congress in 2021 by the Medicare Payment Advisory Commission. And then we have value-based payments. Sounds so logical, doesn't it? I mean, who doesn't want to pay for value and for quality? Of course. The American Association of Family Physicians describes value-based payments as, quote, an aim is to promote enhanced population health management that should result in the improvement of health and/or a systemic cost containment or reduction. Value-based payment uses alternative payment models or pay-for-performance arrangements to create a combination of incentives and disincentives intended to encourage better healthcare decision-making by tying compensation to certain performance measures. So if the care provider can care for you for less than the capitated amount allotted, they get to share in the savings. If the care they provide exceeds the capitated amount, then they're penalized. I guess nurses would ask the question, is using perverse incentives really a good idea for delivering healthcare to people? Healthcare simply does not operate on this theory of supply and demand like a consumer goods market. Healthcare isn't a consumer good, and treating it as such is causing these high prices, and worse, it's costing patients, in some cases, their lives. Why do we keep trying these failed market fixes over and over again? One explanation is because the medical industrial complex is as powerful as they are. And for them, it's no different than Willie Sutton's explanation when he was asked why he robs banks, because that's where the money is. But nurses know that profiting from another human being's suffering is immoral and unconscionable. Cost containment is key to achieving universal coverage, but trying to use the current system to get to universal health care won't work because the system is just too expensive and it's as it's currently designed. Seriously, isn't it more politically feasible to get the cost of care down than to add complexity and fragmentation, all of which add costs? This convoluted, dangerous system needs to go. And the one we know will do the four things that we all want from our healthcare system: cover everyone, save money, improve quality, and most importantly, save lives, must be implemented. And that system is Medicare for all. We're in a crisis now. We can't keep tinkering. We know what has to be done. We just need to have the political courage to do it. The voters are overwhelmingly with us. This isn't about being politically correct. It's about having the knowledge of how we got here, whether through a Democrat or Republican administration, because this work has been bipartisan, to solidify our position that the only way to guarantee truly affordable healthcare for all, no exceptions, is through a single-payer healthcare system. Your nurses are rejecting the politics of fear and embracing the politics of hope and possibility as they fight for true healthcare justice, not more of the same failed incremental changes, because as David Lloyd George says, you can't cross a chasm in small steps. I hope this presentation has provided a foundational understanding of how we got to the system we have now, the impact of the false claims of why healthcare costs so much in the United States, and inspires you to continue your activism in the fight to achieve healthcare justice by either implementing HR 1976, the Medicare for All Act of 2020, or beginning that process through a state-based single-payer system. And to finally end with a quote from the great labor leader, Dolores Huerta, "Si se puede." Good night, everyone.